So it's important to know about the developmental stages of blood cells. And so this chart gives you a general overview of where and how the various blood cells develop. You may want to refer back to this periodically as we're talking about different types of blood cells and the abnormalities that may be happening to them as a result of disorders in development. White blood cells are divided into granulocytes and agranulocytes, and basically what that means is that they either have granules in their cytoplasm or they don't. So that's a pretty easy way to remember them. The granulocytes consist of neutrophils, and they are primarily pathogen-fighting cells. Eosinophils help to control allergic reactions, and they also fight parasites. Think back to pharmacology when we were talking about the anti-parasitic medications. If somebody has a parasite, then when we look at their CBC, we would see an increase in their eosinophil count. Basophils are blood cells that release heparin, histamine, and other inflammatory mediators. So they get that inflammatory process going. So in a case where we have an inflammatory disease, we would see our basophils higher. Mast cells we talked about extensively when we were talking about allergic reaction or hypersensitivity reactions. Remember, I told you that when you think about allergies, think about mast cells. They are tissue cells that release heparin, histamine, and other inflammatory mediators, and they're involved in allergic reactions. When we think about agranulocytes, we think about lymphocytes. Lymphocytes are further divided into B cells. Our B cells are from the bone, B for bone, and they're involved in our antibody production and our humoral mediated immunity. They produce antibodies. T cells form in the thymus, and so, T for thymus. And they consist of our T helper cells, which are also known by CD4. CD comes from the term clusters of differentiation that defines the surface proteins that are on those T cells. So the CD4 cells activate immune responses. The cytotoxic T cells, or the CD8 cells, are the cell-mediated immunity. And then there's the natural killer cells, that they kill the foreign cells in innate and natural immunity. Monocytes are also included in this group, and macrophages come from the monocytes, and they are the largest number of white blood cells. They are antigen presenting cells, and they produce inflammatory mediators. I substituted this chart in your for the one that your book put in because it's a little more detailed and it has a little more info that I want you to know, and there's a big reason why I want you to know it. When we talk about infection, we often look at the differential on the CBC. The differential shows the percentage of the different types of white blood cells, but more importantly, it also shows the percentages of immature cells. We call them bands. If the band count is high, it means that the infection has used up the mature cells, and now the person is producing more immature cells in an attempt to manage the infection. The more immature cells there are, the sicker your patient ultimately is. And we look at the IT ratio to see how many immature cells there are compared to the total number of of, neutrophil numbers. The other part of this too is I mentioned the band cells, but if you look at these different the neutrophils, you'll see that if your patient is really sick, we'll see even more immature cells. And that's really a bad sign when we see cells that are even more immature than the band cells. Another thing that I want you to think about with this is we have a little term called left shift. So if you took this particular picture and you turned it on its side so that the immature cells are on your left side and the mature cells are on your right side, that's why we call things left shifted. Back in the olden days when they started looking at the development of these white blood cells, they would draw them with the most immature cells on the left, and then as they went across the picture, you would have the mature white blood cell on the right. And so then people started referring to your very, very sick patient as being left shifted because you saw more immature cells in their CBC. So that's where that thing came from. Don't, there is no such thing as being right shifted. That just means that you're normal. And a lot of people get this whole idea of left shifting. They start thinking that it has some special meaning, but really it's just a matter of looking at the numbers of immature cells that there are in the blood. And the whole phrase came from just the drawing to demonstrate that. Although both precursor B and T lymphocytes begin their development in the bone marrow, they migrate to peripheral lymphoid structures to complete their differentiation process. B lymphocytes mature, though, in the bone marrow, and then they differentiate into plasma cells and move into the lymph nodes, where they continue to proliferate and produce antibodies. T lymphocytes leave the bone marrow as precursor T lymphocytes, and they travel to the thymus where they differentiate into the CD4 helper cells, helper T cells, the TD8 cytotoxic T cells, and the killer cells, after which many of them move to lymph nodes where they undergo further proliferation. Lymph nodes consist of organized collections of lymphoid tissue located along the lymphatic vessels. Usually they're typically grayish white and ovoid or bean shaped. They range in diameter from about 1 millimeter to 2 centimeters. The cortex contains well-defined B cell and T cell domains. The superficial outer cortex contains aggregates of cells that are called follicles. The mantle zone is where the small layer of B cells surround the germinal centers. The cortex around the follicles is called the paracortex. In that paracortex is the area that contains most of the T cells in the lymph nodes. Like normal lymphocytes, malignant B and T cells tend to go to the particular nodal sites where they normally would live, and that leads to characteristic patterns of involvement in that lymph node. So, like always, we've got some vocabulary to learn. In leukopenia, it's defined as a decrease in the absolute number of white blood cells. Neutropenia, or agranulocytosis, is an abnormally low number of neutrophils, and it's defined as being less than 1,500 neutrophils per microliter. There is a benign form of neutropenia that's called benign ethnic neutropenia, and it tends to affect people of African descent and some Middle Eastern ethnic groups. Aplastic anemia is when all of the myeloid stem cells are affected, and it results in anemia, thrombocytopenia, and agranulocytosis. So let's talk about some of these diseases that are related to the white blood cells. In mononucleosis, it's a self-limiting disease. It's caused by the Epstein-Barr virus, and it's spread through oral secretions, hence why it's often known as the kissing disease. Humoral and cellular immune responses serve to control viral shedding by limiting the number of infected B cells rather than eliminating them. Basically, once you're infected with Epstein-Barr virus, it's a herpesvirus. You're infected with it for life. It's in your body forever. And periodically you'll shed the viruses, and they feel like this disease is spread by people that are asymptomatic, that are having these periods where they shed the virus. In the clinical course, the incubation period is anywhere from 4 to 8 weeks. There's a prodromal period for several days where the person just feels yucky. They may not feel like eating, and they may have a little bit of fever and chills. The illness itself usually lasts for about 7 to 14 days, where there's fever and pharyngitis. And the pharyngitis is one of the major symptoms that are associated with it. It's most severe on days 5 through 7. There's lymphadenopathy, and which means that the lymph nodes are swollen. And there may be a little hepatitis, so the liver is swollen and inflamed. There also, one of the biggest parts of it is that there's splenomegaly, which is caused by the white cells being entrapped in the spleen. And although your book talked about it as though it was no big deal, the big concern that we have with this, with mononucleosis, is the potential for the spleen to rupture. And so, if somebody does have mononucleosis, we advise them to stay away from contact sports for a minimum of 3 weeks after their symptoms have resolved. Recovery without incident usually takes up to 2 to 3 months, And in children, we'll often advise them to stay away from those contact sports during that entire period. The treatment is symptomatic, so basically we're trying to treat the symptoms. So we give them antipyretics for their fever and their pain because obviously pharyngitis hurts. Doing things that help them feel better by increasing liquids and basically whatever helps them feel better and rest. There's several neoplastic disorders of the hematopoietic and lymphoid origin. The myeloid neoplasms are caused by mutation of the myeloid cell line. And there's an overproduction of abnormal monocytes or granulocytes. Basically, what happens is these abnormal cells replace the normal bone marrow cells, and we have both acute and chronic uh, versions of those. Primarily, we're looking at myelogenous leukemia. In the lymphoid neoplasms, we have mutation of the lymphoid cell line, and it results in an overproduction of abnormal immune cells. So we end up with abnormal numbers of lymphocyte B and T cells, leukemia, and Hodgkin's and non-Hodgkin's lymphomas. Leukemia is one of those cancers that most people have heard about. Results from a malignant neoplasm of the hematopoietic stem cells, and you create abnormal white blood cells. We have the lymphatic um, cells. So we have ALL, which stands for acute lymphocytic leukemia. It's the most common form of leukemia. And then we have the chronic form, the chronic lymphocytic leukemia. We have myelocytic leukemia as well, which means we have the acute myelocytic leukemia and the chronic myelocytic leukemia. And there's also one known as the biphenotypic, which means it has more than one type of cell involved. The causes is unknown. However, there is a correlation of having leukemia after exposure to radiation or as a second cancer after treatment with chemotherapy, uh, certain chemical exposures, and there actually is some genetic leukemias. So we often can see some family history of leukemia. Your book went into a lot of detail about this Philadelphia chromosome, and it went into a lot of stuff about all this translocation, how it happens, and all this kind of stuff. But basically, what I want you to know about the Philadelphia chromosome is that it was the first chromosome associated with cancer that was discovered. And it is a translocation between chromosome 22 and chromosome 9. And that's really all you need to know, is that this chromosome is associated with leukemia, and that it comes from this translocation. So what's the difference between acute versus chronic? Well, acute is associated with a sudden onset of signs and symptoms of depressed bone marrow function. So we see that with acute lymphocytic leukemia or acute myelocytic leukemia. It tends to affect younger people. The chronic form involves more proliferation of fully differentiated myeloid and lymphoid cells. Again, it ends up being CLL and CML, and it tends to affect older persons rather than younger people. So we know that leukemia affects bone marrow activity. So then the question becomes, how would this cause bone pain and risks of fractures? Well, we know that there is an overproduction of these blood cells in the bone marrow. This causes the matrix of the bone to not be as strong because it's doing things that it normally wouldn't be doing. There's more pressure inside of the bone. And so this increases the risk of fracture, and it also causes the bone pain. As far as anemia is concerned, there's bleeding due to decreased platelet count, and um, and this causes the anemia that's associated with leukemia. As far as the thrombocytopenia is concerned, again, you're more prone to infection due to the neutropenia and the general um, adenopathy and the splenomegaly and the hepatomegaly that's associated with all of this, because it's not just um, the white cells that are being affected. The platelet cells are also being affected by this. That doesn't make. Leukemia affects the bone marrow activity in general. And so then your question becomes, how would this cause bone pain and risk of fracture? Well, what happens in there is that the bone marrow expands. And because of the expansion, it makes the bone thinner and more easy to break. This expansion inside of the bone marrow also causes this bone pain that's associated with it. A lot of times kids will just say, my bones hurt, which is kind of an odd way of saying it, but yet they're really explaining what hurts. The anemia is often caused due to decreased platelet counts. And so as a result, they bleed more and can have some minor internal bleeding, and so that results in the anemia. The thrombocytopenia is due to these overproduction of these white cells. Well, you would think, oh, overproduction, that's great. We have lots of white cells. Well, not really, because these are abnormal white cells, and so they don't fight infection the way they ought to. And so, in many ways, even though they're there is a neutropenia associated with it, along with the lymphoadenopathy, which means the lymph cells are not responding as they should. The the spleen is pulling out all these abnormal cells and filling up with those, which is part of why we have the neutropenia. And and then because it's where all these cells are being destroyed, that's how come we have the hepatomegaly. So basically, we have hepatosplenomegaly in most cases. There's immune suppression that goes along with it, again, because of all of these other things that we just talked about. And so one of the things that's kind of interesting is that the leukemic cells can cross the blood-brain barrier, and they can establish themselves in the central nervous system. And so as a result, symptoms that we get with that are cranial nerve palsies, headaches, nausea and vomiting, um, and occasionally seizures and coma. Some of these other things that we've talked about are associated with symptoms of fatigue. So if you're anemic, you're going to be fatigued. They may have low-grade fevers, night sweating, and weight loss due to that rapid proliferation and hypermetabolism of those leukemic cells. The diagnosis is based on blood and bone marrow studies. They often will do a lumbar puncture to see whether or not there's CNS involvement as well, and they will often do imaging studies, CTs or MRIs of the chest, abdomen, and pelvis, looking for involvement in those areas as well. The treatment is chemotherapy, and in some cases, they'll do bone marrow or stem cell transplantation to help treat it. A lot of people get the lymphomas mixed up, the non-Hodgkin's versus the Hodgkin's lymphomas. And so I wanted to put these side by side so that you could see the differences between them. The non-Hodgkin lymphoma has clinical manifestations that are dependent on the type and the stage of the disease. Typically, they have painful lymphadenopathy, which means swelling of their lymph glands. And they may have fever, they have drenching night sweats, and they have weight loss. The diagnosis is with a lymph node biopsy, and treatment is normally radiation therapy, and sometimes they'll add chemotherapy for the more advanced disease. In Hodgkin's lymphoma, they have malignant B cells invading the lymphoid organs. So if you think about this, remember the B cells are kind of sitting out on the edge of the uh, lymph nodes. There's two groups that most commonly get Hodgkin's lymphoma. The first group are early adulthood, 15-year-olds to 40-year-olds. The second group are older adults, age 55 or older. And the Hodgkin lymphoma arises from a single node or a chain of nodes. So basically, it infects one node, and if you don't notice it early enough, it moves on to the next node along the line, which is why we say a chain of nodes. It has a unique thing called a Reed-Sternberg cell, and that is the diagnostic indicator for Hodgkin's lymphoma. So when they're doing a node biopsy, they're looking for this Reed-Sternberg cell. They don't know what causes it. It just happens. And the clinical manifestation is that there is a painful enlargement of a single node or a group of nodes. And there's often mediastinal masses that will cause chest discomfort with cough or dyspnea. There's fever, chills, and night sweats, but not as bad as the night sweats that come with the non-Hodgkin's lymphoma. And there's also weight loss associated with it. So both of them have this fever, night sweats, and weight loss. Like I said before, the diagnosis is made by seeing this Reed-Sternberg cell in the node biopsy. And the treatment tends to be radiation and chemotherapy. Myelomas are abnormal B cells in plasma cells. These can form tumors, and they're more common in people of African American descent. We also see it primarily in the elderly between the ages of 63 and 70. It produces abnormal antibodies, and so what we see is immune depression, and proteins increase the blood viscosity, and it infiltrates organs. So think about that. If the blood viscosity is increased, we're going to see increase in blood pressure. We're also going to see other things associated with the blood not moving as easily through the vessels. It is it's a proliferation of osteoclasts. So we see breakdown of the bone. So bone pain is usually the first symptom associated with myelomas. The diagnosis is based on the clinical manifestations and blood tests and bone marrow exams. The treatment is kind of interesting because the treatment is the thalidomide with dexamethasone. If any of you remember, thalidomide was the drug that they gave to mothers back in the 50s and early 60s to try to prevent spontaneous abortion or miscarriage. And so what happened with that drug is it caused shortened limbs, and you had these kids with basically just little uh, flippers on the side of their where their arms should have been. Um, but what's interesting is that we've found out that this drug is good for other purposes, and it does treat myelomas. There's also a drug known as bartezomig that's used for treatment of myelomas. Uh, Although it hasn't been shown to help a whole lot as far as treatment, high dose chemotherapy is given to knock out the immune system, and then they give autologous stem cell transplantation in some patients. This chapter is going to talk about hemostasis and disorders of hemostasis. Hemostasis basically just means to stop bleeding. In normal situations, when we have a cut or a bruise, the blood components seal over the blood vessel and the bleeding stops. In abnormal situations, we have inappropriate clotting or insufficient clotting. When we think of clotting, the first thing we usually think about is platelets or the thrombocytes. They normally live 8 to 9 days in the circulation, and many are stored in the spleen. They're released when they're needed. They are the large fragments of megakaryocytes in the bone marrow are stimulated by thrombopoietin that results in platelet production, and the platelet productions are made in the liver, the kidney, the smooth muscle, and the bone marrow. And of course, here's a little picture off to the side of what's involved inside of a platelet if you were to open it up. Like I said, we normally think about platelets when we're thinking about coagulation, but in actuality, the plasma proteins are very involved in the coagulation process. The plasma proteins circulate as inactive procoagulation factors, and most are synthesized by the liver. Von Willebrand's factor is made by megakaryocytes and the endothelium. Calcium, which is factor 4, is required by all of them to be produced. A clot is not supposed to be there forever, so there are proteins that begin the process of removing the clots that are no longer needed. One more thing about these plasma proteins is that they're identified as a factor with a Roman numeral attached to them. So we have factor 4, we have factor 8, so that's how we identify them. Just going back to the previous slide, I am not going to have you memorize the whole clotting factor cascade. You learned that once, at least in your anatomy and physiology class, and so we are not going to spend a bunch of time learning the clotting cascade. You just should know it because it's just part of how things work in the body. And as nurses, we should know those things. There are mediators of hemostasis, and they go in 5 stages. The first stage is constriction. Right after an injury is constriction of the blood vessels, or a vessel spasm. The second stage is formation of the platelet plug. The third stage is coagulation and development of insoluble fibrin clot. And then the fourth stage is the beginning of the healing process where the clot starts to retract and get smaller. And finally, the fifth stage is clot dissolution, or basically it has to go away. Like I said previously, these clots aren't supposed to be there forever, so those final 2 steps are the steps to remove the clot in the healing process. So let's look at an example. A man had a stroke and the doctor gave him tissue plasminogen activator, or TPA. So why did he give it to him, and what's the doctor trying to accomplish? Well, plasminogen activator, TPA, activates plasminogen, which leads to the clot dissolving. So with his stroke, he had a clot that went up to his brain and blocked off an artery supplying oxygen to his brain, to part of his brain. And so by giving the TPA, we are reperfusing the area that the clot has blocked off. So one of the man's relatives wondered why the doctor didn't give him heparin or warfarin instead. What's the difference? And why might TPA be more appropriate? Well, like we said, TPA causes the clot to break up by activating the plasminogen, which activates plasmin, which breaks the clot up. Heparin works by inactivating thrombin in the clotting process. So basically, it's preventative. And so it stops the blood clot from forming. So this is too late for this guy. He already has a clot. So heparin isn't going to do anything. It could prevent future clots from forming, but he already has one, so it's not going to help. Warfarin decreases the body's ability to form clots by blocking the formation of vitamin K dependent clotting factors. Again, It's a preventative medication. The man already has the clot, so we need a medication that's going to actually work on the clot that's there. Hypercoagulability, or overability of the blood to clot, is one of the major problems we have with hemostasis. It can be caused by increased platelet function, meaning that we have an increased platelet number. We call that thrombocytosis. It can also be caused by blood flow disturbances, for instance, by atherosclerosis. The atherosclerosis stimulates the platelets in that area to aggregate or stay together and form a clot over that atherosclerotic area. We've been talking about that earlier. Or we can have endothelial damage. Endothelial damage causes platelet aggregation in that area in the vessel. And then we can have problems with the platelet aggregation itself, that they may be hyper aggregating or sticking together. We could also have problems with accelerated coagulation system activity, like an increased procoagulation factors, a Leiden mutation, which is an inherited disorder, causes venous thrombosis and recurrent DVTs. We also have something known as antiphospholipid syndrome, which also leads to increased coagulability. And then we can also have a problem of decreased anticoagulation factors, so that would cause clots to form more easily. On the opposite end of the spectrum, some of the platelet disorders we have are related to decreased platelet levels. We call that thrombocytopenia. Remember, platelets are thrombocytes. We define thrombocytopenia as being less than 100,000 platelets per microliter of blood. This can be caused by decreased platelet production or decreased survival. In one case, it can also even be caused by increased destruction by something known as disseminating intravascular clotting, or DIC, or thrombolytic thrombocytopenic pura, or TTP. Or we can have excessive pooling of the platelets in the spleen. We call that splenic sequestration, rather than having them going all over the body. Another cause of decreased platelets can be cyclooxygenase enzymes, or the COX enzymes. These are arachidonic acid is released from the membranes. We have COX-1, which catalyzes the production of thromboxane A2, or COX-2, that catalyzes the production of prostacyclin. Aspirin and NSAIDs are known to inhibit COX-1 and COX-2 enzymes. The COX-2 enzymes are what we want to have happen, but they can overproduce. But we often hear about the aspirin and NSAIDs as being desirable things because it inhibits the COX-1 and COX-2 actions. So why is aspirin used as a blood thinner? Well, it's inhibiting the COX-1 and COX-2. Why is blood thinner not the best description? Well, it's not making the blood any thinner. What it's doing is inhibiting the platelet aggregation so that the platelets don't form a clot. So, really, it's not thinning the blood, just like warfarin and heparin are not thinning the blood. It's just making it so that it doesn't form a clot. Book talked about a couple different disorders related to clotting factors. We're going to primarily focus on the hemophilia A. Hemophilia A is an X-linked recessive disorder that primarily affects males. And I say primarily because there are a few mosaics that actually will affect females as well, but usually not to the extent that it affects the males. The percent of factor VIII in the circulation depends on the genetic defect and determines the severity of the disease. Bleeding occurs into the soft tissues, the GI tract, the hip, the knee, elbow, and ankle joints. This results in inflammation of the synovium, which results in acute pain and swelling. Over time, this leads to joint fibrosis and contractures. Prevention of trauma is very important with somebody who has hemophilia A. If you think about it, if they get any type of head injury, they can have increased bleeding into the brain because of the lack of these clotting factors. These patients need to avoid aspirin and NSAIDs since that affects platelet aggregation. It further decreases their ability to clot. Factor VIII replacement therapy, which is an infusion, IV infusion, is started when the bleeding starts. If you look back historically, it was a major cause of HIV infection prior to the 1980s when we started checking the blood supply for HIV. The factor VIII is a pooled product, meaning it comes from multiple people. And because it comes from many, many different people, it increases the risk of HIV being transmitted to the people that are getting it. Many of the children who were receiving factor VIII infusions developed HIV infection and later went on to develop AIDS before we had some of the better treatment protocols that we have now for HIV. Ryan White, who a lot of the legislature that protects people with HIV infection was named for, he was a young boy who had hemophilia and developed HIV infection because of his use of the factor VIII. His family was denied housing because of his infection, because everyone was so afraid of HIV, and there was so much prejudice against people that were HIV positive. It led to a lot of legislation that is helping with the financial and housing issues that people with HIV face. DIC, or disseminating intravascular coagulation, but basically means it's happening all over the body, is a very complex disease. And if you look at the schematic about it, it affects the intrinsic pathway, by because if there's been some type of endothelial injury caused by trauma, burns, um, hypoxia, acidosis, shock, DIC really is associated strongly with shock. It leads to thrombin generation. It can also happen by the extrinsic pathway, meaning that there's been trauma, obstetric complications, or complications related to cancer that also may have activated the thrombin generation. So now we've got a lot of thrombin happen in the circulation, and with thrombin in the circulation, we have clotting happening. So first what happens is we have hypercoagulability, and with that, the patient develops microemboli, and that happens out in the tissues, in the heart, in the brain. It happens everywhere throughout the body. After that thrombin starts up, or after those microemboli are developed, plasmin gets activated, and it results in the clotting factor degradation, and that leads to bleeding. So we've got this combination of stuff going on. We've got clotting happening at the same time as we have bleeding happening, because all of this is going on all at the same time. So what happens is we get tissue ischemia from the emboli to the brain, the kidneys, the heart, and the lungs. This person is really, really, really sick. The treatment to manage the disease, is aimed at treating whatever caused the problem in the first place. So if trauma was the cause, we've got to treat the trauma. We have to treat the injuries that are related to it. If acidosis is what caused it and sepsis or shock is what caused it, then we've got to treat the sepsis, and we've got to treat the shock and the acidosis. And by correcting the acidosis, then it helps to decrease this cascade that's going on. After that, we have to take care of what's happening, because even though we're treating what's initially causing the problem, we still have activated this cascade. And so it usually requires us replacing the clotting components and preventing further activation of the clotting mechanisms. So we often give fresh frozen plasma. The fresh frozen plasma helps to dilute the plasma proteins that are going crazy. It also has clotting factors in it, and so the area where the plasmin is acting, it's starting to act on the bleeding aspect. We'll give platelets, because again, bleeding is one of the major things, and these people literally are bleeding from everywhere. If they've been stuck for an IV, they're bleeding from their IV site. If they've been, if they had an injury, they're oozing and bleeding from their injury. It's really something to, they'll bleed from their lungs, they'll bleed from all sorts of different places. Often we'll give cryoprecipitate, because cryoprecipitate has fibrinogen in it. Some people believe that giving heparin may help to decrease the blood coagulation, but that is an extremely controversial treatment because there's so many other aspects to this disease process. Um, Here they only talked about the DIC itself, but the DIC also causes changes in blood pressure, usually hypotension. So patients with the DIC are often on inotropes as well. If it's been affecting the microcirculation has affected the heart muscle, the heart may not be beating adequately, so they need these inotropes so that you have adequate contraction of the heart to raise the blood pressure. These are very, very, very sick patients, and they're usually in the ICUs. And finally, we're going to talk about red blood cells. Red blood cells are dependent on hemoglobin, and there's two types of hemoglobin. The first type is known as adult hemoglobin, and in adult hemoglobin, there's two alpha chains and two beta chains, so there's four hemoglobin molecules that are hanging onto the oxygen. Each protein chain holds one iron containing heme group, and oxygen binds to the heme groups. Fetal hemoglobin is different, and it is the hemoglobin that the fetus has before it's born. And so, unlike the adult hemoglobin that has two alpha chains, it has two gamma chains, and it also has two beta chains. The gamma chains make it more have a higher affinity for oxygen than the adult hemoglobin. In other words, the gamma hemoglobin has a stronger pull towards the oxygen, and it tends not to let go of it as easily either. This allows for oxygen to cross the placenta into the fetal circulation and to give the amount of oxygen that the fetus needs to be able to grow. It also allows for lower oxygen saturation that still gives the fetus and the newborn adequate tissue oxygenation. It's replaced with adult hemoglobin by 3 to 6 months after birth. We can't think about hemoglobin without thinking about iron. So basically, iron is ingested and it's absorbed into the blood system. The iron is transported in the plasma to the liver as transferrin, and we can check how much iron is in the body by checking a ferritin level. And so, if you ever want to know if the person is getting enough iron in their diet or they have enough iron in their circulation, we would do a ferritin level. Iron itself is stored in the intestine, the liver, and in the bones. And those are the places where it will be needed the most. Erythropoiesis is the development of red blood cells. Contrary to popular belief, it's not just stimulated in the bone and produced in the bone. It actually requires decreased blood oxygen, which causes the kidneys to secrete erythropoietin. Remember, though, that erythropoietin can also be produced by recombinant DNA technology, and its brand name is known as Epogen. Um, Erythropoietin stimulates the bone marrow to produce immature red blood cells, which turn into reticulocytes, which eventually turn into red blood cells. So here's a nice little picture showing how that happens. Red blood cells last about 120 days. Eventually, the red blood cells break as they squeeze through the spleen capillaries, or they just have their natural death. Phagocytes from the spleen, the liver, the bone marrow, and the lymph nodes ingest and destroy the red blood cells. Heme from the red blood cells are processed into bilirubin in the liver. And the metabolic activity of the red blood cells decrease with age, and that causes this weakened membrane that makes it so that they break. Bilirubin that's processed in the liver turns into bile. It also is what causes our urine to be yellow. I find it interesting that the author likes to use such big words all the time and then didn't use the big word that goes with RBC destruction, which is erythematosis. So erythematosis is a form of apoptosis, or programmed cell death, and it is the aging and death of mature red blood cells. As the red blood cells ages, it undergoes changes in its plasma membrane that makes it susceptible to selective recognition by the macrophages and subsequent phagocytosis in the reticuloendothelial system. In other words, the spleen, the liver, and the bone marrow. This process removes old and defective cells and continuously purges the blood. Erythematosis normally occurs at the same rate as erythropoiesis, keeping the total number of circulating red blood cells in a state of equilibrium. Many diseases that involve damage to red blood cells, like hemolytic anemias, sepsis, malaria, pernicious or nutritional anemias, or normal cellular processes that cause cellular damage may increase the rate of erythematosis. Conversely, erythropoietin and nitric oxide, which is a vasodilator, will inhibit erythematosis. Following erythematosis, the hemoglobin content within the red blood cell is broken down and recirculated throughout the body. The heme components of hemoglobin are broken down into iron ions and a green bile pigment called biliverdin. The biliverdin is reduced to the yellow bile pigment bilirubin, which is released into the plasma and recirculated to the liver. Then it's bound to albumin and stored in the gallbladder. Bilirubin is excreted through the digestive system in the form of bile, while some of the iron is released into the plasma to be recirculated back into the bone marrow by a carrier protein called transferrin. This iron is then reused for erythropoiesis, but additional dietary iron is needed to support healthy red blood cell life cycles, which is why you need to eat plenty of iron-rich foods. Causes of anemia include blood loss, hemolysis, or impaired red blood cell production. So we're going to talk a little bit about a couple of disorders that are related to those things. Anemia, or the decreased number of red blood cells, are caused by blood loss, hemolysis, or impaired red blood production. And so, since this is the primary issue involving red blood cells, this is what we're going to talk about first. And we'll talk about a few causes of these different reasons that people have anemia. First, we'll talk about hemolytic anemia. Hemolytic anemia is the premature destruction of red blood cells. Once it occurs, we end up with a retention of iron and a compensatory increase in erythropoiesis. Remember, when red blood cells are destroyed, the iron from the heme is taken back to the bones to produce more red blood cells. There's two different forms of hemolytic anemia. The first form, the inherited, is caused by different types of faulty genes that cause different types of inherited hemolytic anemias. However, in each type, the body makes abnormal red blood cells. The problem with the red blood cells may involve the hemoglobin, the cell membrane, or enzymes that maintain healthy red blood cells. The abnormal cells tend to be fragile and break down while moving through the bloodstream. If this happens, an organ, the spleen, may remove the cell debris from the bloodstream. We often see splenomegaly when that happens. If it's an acquired form, the body makes the normal red blood cells, but the disease or condition or other factors destroy the cells. Some examples of the conditions that can destroy red blood cells include immune disorders, infections, reactions to medications or blood transfusions, and hypersplenism, or an enlarged spleen. Symptoms of hemolytic anemia goes along with symptoms of most of the other anemias: fatigue, shortness of breath, dizziness, headache, cold hands or feet, and pale skin. However, they may actually have chest pain as well. If there's too much hemoglobin, the free hemoglobin in the blood results in hemoglobinemia, which makes the plasma turn red. If it's excreted in the urine, we get hemoglobinuria, which makes the urine darker in color. And it also can lead to jaundice. We diagnose hemolytic anemia with labs, usually things like CBC and retic counts. Remember, if the bones are making a lot of red blood cells, they're going to be making reticulocytes first that mature into red blood cells. A Coombs test shows whether your body is making antibodies against the red blood cells. Liver function tests, bilirubin levels are going to be elevated, so because the liver is having to deal with all of these destroyed cells. Hemoglobin electrophoresis looks at the different types of hemoglobin, and it can diagnose the type of anemia that the patient has. We would do urine tests looking for hemoglobin in the urine, blood marrow testing to look at the type of cells that the bones are producing, and testing to rule out other causes of the hemolytic anemia, like kidney failure, lead poisoning, or vitamin or iron deficiency. Treatment includes blood transfusions, steroids, plasmapheresis, surgery, or bone marrow stem cell transplantation. Sickle cell anemia is considered to be one of these hemolytic anemias. The sickled cells are more likely to be destroyed, causing jaundice and pigment gallstones. The sickled cells block the capillaries, causing acute pain. Infarctions cause chronic damage to the liver, the spleen, the heart, the kidneys, eyes, and bones. Pulmonary infarctions cause acute chest syndrome and breathing problems, and cerebral infarctions can cause stroke. Because sickle cell is an inherited disease, and it affects children and infants. In children, we often see symptoms like from the anemia of pale, fatigued, or having rapid pulse. Children often will develop something called hand-foot syndrome or dactylitis. This picture over to the right-hand side is an example of the painful swelling of the hands, and it can also cause the feet to swell like that as well. This is caused by the blockage of the vessels in the hands and feet. Since it causes breakdown of the cells, the child may be jaundiced with yellow color to the skin and to the whites of their eyes. They often develop frequent infections due to splenic damage with fevers above 101 degrees. They can develop stroke, and with stroke, they'll have symptoms like headache, seizure, weakness of the arms and legs, speech problems, facial droop, and loss of consciousness in some cases. Other symptoms that go along with this include being small for age, chest pain, abdominal pain, coughing, and difficulty breathing. By the time someone becomes an adult with sickle cell, we're starting to see chronic complications, and these can include anemia, leukocytosis, indirect hyperbilirubinemia, chronic renal failure, delayed puberty, retinopathy, obstructive sleep apnea, pulmonary hypertension, cardiomegaly, functional asplenia because of the blockage of the blood vessels in the spleen, avascular necrosis, and skin ulcers. The treatment for sickle cell includes blood transfusion. This increases the number of normal cells, or it is used to prevent complications, especially in children. Children may actually get blood transfusions of red blood cells on a regular basis. Pain medications. Obviously, you saw that little swollen hand, and you know that's got to hurt. And then when you think about the chest pain and other things that are involved with it, these kids and adults are on a lot of pain medications to deal with that pain. Hydroxyurea will reduce painful crises. A crisis is when there's an excessive number of sickled cells. It tends to happen with infection or other stressful situations, and this and so when that happens, you have more blockages of the microcirculation in the body, and more pain and just excessive amounts of pain. This hydroxyurea stimulates the production of fetal hemoglobin, and the fetal hemoglobin prevents formation of sickle cells. But the problem with it is it also increases the risk of infection, which could potentially put somebody into sickle cell crisis. You want to make sure that children and adults are getting their vaccinations because that will help to prevent infections. In some patients, when they have significant symptoms, they may do a bone marrow transplant, which is a stem cell transplant. There's some experimental treatment going on with gene therapy, nitric oxide. Remember, nitric oxide causes vasodilation. So if you have vasodilation, you may not have as much blockage, especially during crisis situations, and other drugs to boost fetal hemoglobin production. I'm not going to spend a lot of time talking about thalassemias. In Patho, we're going to talk about them quite extensively in pediatrics next semester. But they're an inherited disorder where there's a defective gene. In the alpha form, it affects the alpha chain synthesis, and there's 1 to 4 different defective genes that can cause that. This affects both the fetal and the adult hemoglobin, even though we don't have alpha chains in the fetal form. In the fetus, the gamma may form. In the adult, the beta hemoglobin may form as well. And in the beta form, we have a defective gene for beta chain synthesis. There's more than 100 different mutations that can cause this, and it affects only adult hemoglobin. Alpha 4 hemoglobin may form with it. In both cases, what happens is there is an excessive amount of hemolysis that happens, and these patients get high levels of iron. The treatment is iron chelation. Chelation is a word meaning getting rid of or binding a heavy metal or abnormal chemical in the body. So they're given a special medication that causes the iron to bind with it so that the iron can be expelled from the body. And in this case, it would go out through the stool. So I'm also not going to spend a lot of time talking about the different anemias from deficient red blood cell production. Obviously, iron deficiency anemia, we need to have more iron in the diet, and that's going to allow for production erythropoiesis to happen and the heme to form that's causing the deficiency. Megaloblastic anemias include pernicious anemia, which is a B12 deficiency. In those cases, giving them B12 injections are the cure for that type of anemia. Folic acid deficiency means that they need to supplement with folic acid and to make sure that they are eating a diet that is sufficient in folic acid. If you remember, pretty much green leafy vegetables are things that have pretty much all of the things that we need in them to avoid a lot of these anemias. Aplastic anemia is bone marrow depression, and it happens with chemotherapy and with some other medications. Uh, it's it's one of those things that we'll, we've talked a little bit about, I believe, when we were talking about neoplasia with bone marrow depression. You would think that you would want to give more blood, but if you give blood, you're going to cause the bone marrow to depress even more, because the bone marrow is active based on low levels of the blood components. So we give medications like erythropoietin to the patient to help the bone marrow to sort of wake up and start producing the blood components. Um, there's also chronic disease anemias related to chronic inflammation. With chronic renal failure, you're not going to produce erythropoietin, and so you're not going to produce red blood cells. Um, but remember that erythropoietin is produced in other parts of the body as well, but not as high number or high of levels. So they may need supplementation with erythropoietin injections. Even though anemia is the most common problem with red blood cells, if you look at the opposite ends of the problem scale, then we're worried about polycythemia, which is an increased red blood cell count and a hematocrit that's greater than 50%. Remember that you want, ideally, your hematocrit ought to be somewhere between 38 to 40. 45 is even getting a little on the high end. Relative polycythemia is the result of loss of plasma volume, which basically means that we don't have the liquid in the blood, and so it makes it appear that we have polycythemia. But in actuality, if we had a better plasma volume, then it wouldn't appear to have polycythemia at all. Absolute polycythemia is increased red cell mass. Primary form is neoplasia, which is polycythemia vera. It's commonly seen in older men, and it is a type of cancer. Secondary polycythemia is increased erythropoietin production secondary to hypoxia. We see this a lot in people who have heart disease and lung diseases. So when somebody develops, for instance, COPD, they become hypoxic and they become chronically hypoxic. And with that chronic hypoxia, the kidneys are producing more erythropoietin. The erythropoietin is causing increased production of red blood cells. This is actually beneficial to those patients because the increased number of red blood cells allows for better oxygenation of their body. Children that have cardiac defects that are cyanotic cardiac defects, they also produce more erythropoietin and end up with polycythemia. This again is beneficial to them because it allows them to have tissue oxygenation. Remember, there's a difference between hypoxia and hypoxemia. So I wanted to let you know that your book goes on to talk about hyperbilirubinemia of the infant and hemolytic disease of the newborn. Those are both disorders that you will be learning more about in OB, And so I'm not going to spend a lot of time here talking about them. And I don't even have slides on them. That tells you how little I want you to spend your time studying that. But basically, um, it causes them to get jaundice, and they have to have phototherapy to take care of the destruction of the red blood cells that are not being managed well by the liver. And so, and in the case of the hemolytic disease of the newborn, they can actually get so severe that they require what we call an exchange transfusion, where we pull blood out and put blood back in again to replace the overproduction of bilirubin from the destruction of the red blood cells. But that's all you need to know right now. And like I said, there's no slide here, so you probably aren't going to be tested on those. Um, and that's it on this topic.